product profiles. After that, we have a presentation by Nim Arinaminpathy from Imperial College London, who discusses the potential impact of future preventive therapy regimens on the TB epidemic. After that, we'll have a presentation from Kevin Schwartzman from McGill University on the potential cost and cost effectiveness of future TB preventive therapy regimens. The final presentation is by Alberto Matteelli from the University of Brescia, and he will discuss some of the use case scenarios and considerations for special populations. After the presentations, we'll have a live Q&A where you are invited to ask questions via the chat. The Q&A session will be moderated by Christian Lienhardt with support from colleagues here at WHO. Now I'd like to invite Tereza Kasaeva, Director of the Global TB Program at WHO, to say a few words.
Dear colleagues, greetings from Geneva from the WHO Global TB Programs. I hope that in this very challenging time for the globe and for the TB community, you and your families are staying safe and healthy. And another important message from our side, of course, we should not forget about big global problem of TB, about millions of people suffering, still suffering and dying from TB, and of course about this negative impact on the situation with TB of a COVID-19 pandemic. Based on our modeling exercise here in GTB, unfortunately, we can predict additional up to 400,000 deaths because of COVID and as a result of the massive disruption of the TB services in many countries, first of all in high burden countries. So this webinar is one of in the series of webinars with which we are planning to attract your attention and broader audience to very important activities, tools and perspectives for the TB programs. So a quarter of the world's population is estimated to be infected with the TB bacilli, most of whom are not sick or but still they should be in the focus of our attention because of risks of the development of active TB and because of special vulnerability, and in the current situation, prevention is becoming a very important activities. We can at least to protect people from the development two diseases like TB and COVID, which is especially important, keeping in mind that both of them are affecting primarily lungs and could become really very severe. So, you know, again, I would like to repeat it, each year about 10 million people develop TB disease, 1.5 million people die. Offering TB preventive treatment to people at highest risk is becoming essential. And also when we are looking at the global trajectories and the decrease of TB burden, it's very slow, and partly probably because we didn't have before necessary focus on the TB prevention broadly and on the specifically on TB preventive treatment. As you know, last year we had first ever high-level meeting on TB, and which reaffirmed our commitments, our targets from NTB strategy, but also introduced new targets and new commitments with a strong focus on TB preventive treatment. 30 million people should be provided for 5 years by preventive treatment, and categories are also very clear. These should be at least people living with HIV, group of people, household contacts, and with a special focus on children under 5 years old. And targets are very ambitious, as we can see, but unfortunately progress, especially in the two groups of households, is not still so impressive at all. And the reasons are different. The reasons, of course, are partly because of lack of access. Another thing is still that it's not quite clear, population is not aware why this TB preventive treatment is so important, how it can protect, and still we are receiving limited information about completion of the TB preventive treatment. We can understand how the eligible groups are enrolled in the treatment, but if they're completing, this is another question. And total adherence to TB preventive treatment is becoming another issue. If you will see our information note and guidance, which we released during the period of COVID, you will see that we're strongly recommending to use more actively TB preventive treatment in these risk groups. And also you could see that with keeping our promises and continuing update of our guidelines on the preventive treatment of TB infection, on the treatment of drug-resistant TB and others. So what is the purpose of these webinars and in general in the exercise of the developing target product profiles? The purpose is to identify what are the main gaps, challenges and opportunities, what could be expected and desired, a cheaper, shorter, easier and better tolerated regime, how we can minimize side effects, how we can increase efficacy, and so provide better options for the specific groups, and also keeping in mind such groups as pregnant women, children and others. The target product profiles on TB preventive treatment is the first one to be developed among others on diagnostics, treatment and vaccines. So it will be important to hear your feedback, to see your active engagement, because it's the essential condition of the effectiveness of our work. So with this, I will stop and will give floor to my colleagues and wish all of us a very effective and useful dialogue discussion and clear outcomes. Thank you very much.
Thank you very much, Tereza. Okay, so I'll give a brief introduction before we go to the next presentation. Just want to provide some background. As Tereza just mentioned, tuberculosis remains a very big problem. Globally, more than 10 million people develop TB annually, with a death toll of 1.5 million per year. That includes deaths attributed to HIV-TB co-infection. HIV is, of course, an important driver of the TB epidemic, with people living with HIV being at greater risk of developing TB disease and dying from it. In addition, there are big challenges with drug resistance, with currently nearly 500,000 incident cases per year and a very high mortality among those cases. The WHO anti-TB strategy aims to reduce this global burden of tuberculosis with a holistic strategy with targets for reducing incidence and TB deaths by 2035. The strategy consists of 3 pillars and a number of underlying principles. And TB prevention is clearly part of the first and the second pillars, where pillar 1 focuses on early detection, treatment and prevention for all, and pillar 2 aims to strengthen health and social sector policies and systems to prevent and end TB. And I also want to point out pillar 3, which is on intensified research and innovation, which also includes the development of new tools, such as, for example, new treatments for TB infection, under which the target product profiles would fall. So the main healthcare intervention available to reduce the risk of TB infection progressing to the TB disease is TB preventive treatment. TB preventive treatment is recommended for people living with HIV, household contacts of bacteriological confirmed pulmonary TB cases, and clinical risk groups. The anti-TB strategy calls for 90% coverage of treatment of TB infection among people living with HIV and household contacts of infectious TB patients. Achieving the WHO anti-TB targets of reducing TB deaths by 95% and reducing new cases by 90% requires the discovery of long-acting and safe drug formulations to treat TB infection. Offering TB preventive treatment to people at the highest risk of developing TB disease will not only protect them from becoming sick, but also cut down on the risk of transmission in the community. And this is critical to end TB locally and worldwide. And to reach the targets, we need to increase the speed at which we are reducing TB incidence. This requires the introduction of new tools by 2025. Among the new tools envisioned are new drugs and treatment regimens for the treatment of TB infection. At the UN high-level meeting in 2018, and this was just mentioned also by Tereza, countries committed to TB prevention for people at the highest risk, including the rapid scale-up of access to testing for TB infection and provision of preventive treatment. And at least 30 million should have received TB preventive treatment by 2022, including 4 million children under 5 years of age, 20 million other household contacts, and 6 million people living with HIV. However, progress to reach these targets has been slow, although for people living with HIV, the target is likely to be achieved. But for household contacts, particularly people over 5 years of age, the targets are still far off. There are, of course, many challenges to the programmatic implementation of TB preventive treatment. These include challenges with and these include also challenges with current regimens for TB prevention and the need for better preventive treatment. So Tereza mentioned some of these already. We need treatment of better efficacy. We need safer treatments, treatments that are better tolerated, that are shorter and easier to administer, cheaper regimens, and also consider potential for drug-drug interactions and their propensity to generate drug resistance. And we need to focus on specific patient populations, such as people living with HIV, pregnant women and children. The target product profiles for tuberculosis preventive treatment that we're launching today aim to identify the key product characteristics to be considered for the development of the best and most suitable TB prevention treatments that would allow for large-scale implementation. And as such, they should assist in aligning the treatment developers' performance and operational targets with programmatic needs at country level. I just want to briefly mention a little bit about the development of these target product profiles. There was a scoping group involved who had a meeting to review evidence that was collected, which consisted of a systematic literature review and a pipeline analysis of TPT regimens currently being developed. They discussed the baseline elements that should be in the target product profiles. And we also had, and that will be presented today as well, a mathematical modeling to help identify treatment characteristics with the biggest epidemiological impact on the TB epidemic in different settings, as well as cost effectiveness analysis of implementing regimens with optimal characteristics and reaching the target versus the 6 months of INH at current coverage. So some of these results of the modeling that went into the development will be presented today. So finally, before I hand over to Christian Lienhardt, I'd like to acknowledge the various people that were involved in the development of these target product profiles. Some are mentioned by name, but there were many more members of the scoping group. I also like to acknowledge the contribution of several people and organizations during the public consultation. And then, yes, I think I'll end here. And then I'd like to invite Christian Lienhardt to take over, and he will present to you the content of the target product profiles for TB preventive treatment.
Very good. Thank you very much, Saskia. Please tell me whether you see the screen.
Yeah, we can see your screen. Yeah, it's perfect.
Okay. So thank you very much, Saskia. Thank you very much to the whole Global TB program, Dr. Kasaeva, Dr. Zignol, and Dr. Falzon, to have invited me to assist them in contributing to developing these target profiles for TB preventive therapy. This work has been, of course, the work of several. I've been here more than a scribe, more than anything else, in the sense that I've been putting together ideas submitted by a lot of various people who've been contributing to the target product profiles. So I'm going to show you the main aspects, starting with rationale. I mean, that has been already explained to you both by Dr. Kasaeva and by Saskia. But the development of short, safe, efficacious, and easy-to-take regimens for prevention of TB disease requires detailed information on the safety and toxicity of the regimen's component, their potential for drug-drug interaction, and the propensity for development of resistance, as well as the use in specific patient populations, such as persons living with HIV, pregnant women, and children. Therefore, the target product profiles are a document which is listing what we can name as the product attributes to be considered in developing this, what is expected to be the best and most suitable TB prevention treatment. And it is to be developed according to what would be needed and what would be usable under national health program conditions. The overall objective of this target product profiles is to assist developers in aligning the performance and operational characteristics of new TB preventive treatment regimens with the needs of the end users, that means whoever is going to use the regimens in public practice, in programs, and all public health aspects. The target audience is very wide because it goes from the pharmaceutical industry, academia, research institutions, product development partnerships who are working on trying to find and to identify the best regimens, but also the non-governmental and civil society organizations, as well as the donors who are contributing to the development of these regimens. So, as I mentioned, the targets are defined for a series of attributes, and these attributes represent the most important performance and operational characteristics that are suitable for new TB preventive treatment. For each attribute, we have together selected targets that are expected to meet specific requirements, which are grossly arranged according to minimum and optimal requirements. The minimum requirements seek to improve the current standard of care to an acceptable minimum considered as such for global health impact of a candidate regimen. On the other side, the optimal requirements specify the performance and use characteristic of what could be considered an ideal product with a maximum broad, deep, quick, and aspects and the most sustainable global health impact. So we are here ranging between a window of what will be at least the minimum that will be required, and if really we can get everything we want, what would be the optimal targets that we are seeking to meet. There are criteria for definition of targets, and this should be quantitative in nature so that we can measure them and be sure that we can reach them. And of course, the rationale that support every target should be clearly described, and I will show you about that. So these attributes, how to discuss, how to identify them. As I said earlier, it represents the most important performance and operational characteristics that are suitable for new TB preventive treatment. So the performance characteristics, for instance, are efficacy, safety, barrier to emergence of drug resistance. These are really what we would wish the new regimens to be able to perform and to deliver in terms of activity. And then there are operational characteristics. That means how this regimen should be available to practice, and what about eligibility criteria, to whom they can be given, what would be the duration of treatment, what would be the request in terms of treatment monitoring, management of adverse events or severe adverse events, drug interaction, whether specific tests would be needed for safety monitoring, for instance, a drug that has impact on QT prolongation at the electrocardiogram means that we have to make an electrocardiogram to patients, etc. Then we need to be really considering the issue of whom will be received the treatment, whether there are special populations, HIV infected, children, pregnant women, and then all the scale-up activities are to be considered. So these are the overall attributes as we can define them. And then as you realize, when we define these attributes, we can consider that some of them are to be priority. That means if they are not there, then we cannot reach what we are looking for. So they are really making the ground for a go, no-go decision. We want them to be satisfied. So these are the priority attributes. And those other which are less essential could be the place of potential trade-offs, and they are defined as desirable. If they can be met, it's better. If they cannot, provided that we have all essential ones, then it's considered as a minimum. So a matter of trade-off, and I will come back on that later, is that if a new regimen were to be better tolerated or have greater efficacy, a trade-off in a desirable area, such as the number of drugs in a regimen, could be justified. That means, okay, if it's good, but we have 3 drugs, it's better than something less good with only 1 drug. And of course, the go, no-go decision does not apply to the desirable attributes because that's part of the definition. So which attributes have we selected to address in this current target product profile? So the priority on the left side and the desirable on the right side. The priority are the indication, whom should receive the regimen, efficacy, duration of treatment, safety, tolerability, drug-drug interaction and metabolism, the barrier to emergence of drug resistance, that means the propensity to develop or not resistance in the individual, in the terms harbored by the individual, the target population, the formulation, dosage, frequency, and route of administration, and the stability and shelf life. Desirable are the cost of regimens, special population, treatment adherence and completion, and drug stability testing in index TB patients. So on this basis, we have given targets to each of these attributes, either priority or desirable. And then the targets are meeting the minimum or the maximum optimal requirements. And all these are summarized in what we call the TPP summary tables, which include the respective regimen attributes that can be identified, and then the relevant minimum and optimal target. Again, the minimum target represents the acceptable minimum for global health impact when we develop a candidate regimen. And this is really the go, no-go decision to be used throughout the development process. If drug developer can make sure that they have these minimum targets and then they can continue developing the product, then it is fine. And then the optimal targets, that's the set of performance and used to characterize an ideal product with an expected high global health impact. The elements of the rationale for selection of minimum and optimistic targets are provided in a dedicated annotations column. As I mentioned earlier, it is extremely important when we give a target that it is measurable, that we can quantify it, but also to justify and give a rationale. And here I give you an example. This is the first page of the summary tables of proposed attributes for preventive TB treatment. Among the priority attributes, the efficacy is a key attribute. As a minimum, it has been said that the regimen should have an efficacy not inferior to the current standard of care for treatment of TB infection, which is represented by either 6 months isoniazid or the combination of 3 months isoniazid and rifampicin. On the reverse, the optimal aspect is a regimen with efficacy superior to the current standard of care regimen for the treatment of TB infection, leading to lifetime protection in areas of low risk of reinfection. So these are the minimum and the optimal targets for the efficacy attributes. And we give in the annotation the rationale. And we explain here that TPT regimen must be able to provide, sorry, I cannot see what is written on the screen, so apologies. To be effective, TPT regimen must be able to kill bacteria with low growth rates and those that undergo occasional growth spurts, sterilizing, etc. So we give here the justification. And then we have said there's a minimum criteria that it should be at least as good or not inferior to the efficacy of the 6 months INH or 3HP. And we give here in the rationale the indication that these two regimens are known with various trials to give a protection of 0.65 for 6 months isoniazid and 0.58 for 3HP. So these are the type of annotation and the rationale that we give. So a couple of slides now on some aspects that have been also leading us in this development of target profiles. When we are developing TPP, of course, we list all the characteristics, but we are perfectly aware that satisfying all characteristics in a single regimen might be difficult to achieve. And then we might have to face trade-offs, as I mentioned earlier. And then we might be in a situation, or developers might be in a situation where at the expense to get sure that they have a high efficacy and a high safety, they should compromise on treatment duration or on dosing frequency. So it's all a matter of knowing how you will balance this aspect, and then you will leave the all or nothing to some potential trade-offs, again, which have to be completely rationalized. So there are some cross-cutting aspects that mean whatever we consider, and if we look at the TPPs, we are making TPPs for the world, and of course the world situations differ a lot in the world, in various countries, in the various endemicity, various situation of health systems, etc. So there are cross-cutting aspects to be considered, whatever the new TPP regimen, new TPT regimen may be. So the first is safety. One has to consider that preventive treatment is being indicated to individuals who are otherwise healthy, and they do not necessarily consider themselves as persons with a specific sickness. So that takes us to the realization that we need to be very sure that the regimen is totally safe, because people will not understand how to prevent them to getting a disease, we render them sick. And linked to that, then any regimen that looks promising for TB prevention should be tested carefully for safety and tolerability in the same population who are likely to receive it, so that we can make sure that it can be adjusted and adapted to situations. The diagnosis of TB infection, it's an important cross-cutting aspect. Why? Because an efficacious treatment ideally should be coupled with a test to target those at higher risk for disease progression, especially in HIV-infected persons. So that will be an important tool to accelerate progress towards TB elimination. And that's a sign to say that collaboration with diagnostic developers should be considered for the development of suitable companion diagnosis of TB infection. The issue of rule-out TB test, in every situation in which the TB preventive therapy is indicated, then one must make sure that TB disease is formally ruled out in the person who will receive the TBT regimen, because we don't want to be in a situation where inadvertent use of TPT in people with TB disease may generate drug resistance, and we don't want to give treatment for a person who cannot stand it. Drug stability testing for the index TB cases. Ideally, the new TPT regimen should be usable in all conditions and settings and delivered without requiring a drug stability testing of the presumed source case. Again, an ideal situation. And then, of course, in terms of monitoring, it's related to the issue of managing of adverse events. And one wish to have a clinical monitoring which is decreased to the maximum, so that there is no problem in management of the persons who receive TB preventive therapy. Last but not least, the key issue for success of the WHO and TB strategy is the fact that this TPT regimen can be scalable and can be rendered accessible to everybody with a major notion of health equity. And for that, the programmatic efficacy of new TPT regimen will depend heavily on operational factors. I mentioned about the need to consider that in the TPT, but one has to understand that it comes on top of the TPT of the target product profiles when the regimens are being recommended. So one has to think already that whatever the regimen, then we'll have to consider the access to TB infection diagnosis treatment, capacity of ruling out TB, access to and uptake of TB treatment, etc. And here we think that the recent experience with the 3HP scale-up, which is largely tested now all over the world through the Impact for TB major program would be serving for further information. So for this reason, one can consider that the TPPs give indication on the respective attributes to be considered at development stage, but one should be aware that this should not be dissociated from the factors to be considered at the implementation stage. With that, I would like to thank you very much. And here are the list of all the persons who've been contributing to the development of the target profiles. We'd like to thank them, as well as those persons who have been giving comments on the online public web consultation, and of course, WHO Global TB Program, who's been at the initiation and who's been absolutely instrumental to the development of this TPT regimens for the target profiles for this TPT regimen. With that, I thank you very much, and I give the floor back to you, Saskia. Thank you.
Thanks, Christian. That was a great presentation and very good to get an overview of the purpose of the target product profiles, as well as some of the main attributes that are discussed. Thanks very much. Then I would like to invite Nim Arinaminpathy to share his presentation. Yeah, Nim, I give the floor to you. Thanks.
Thank you very much, Saskia. Can you see my slides?
Yeah, we can see your slides. Thank you.
Great. Thanks very much, and I wanted to thank the folks leading this whole effort for the wonderful opportunity to take part in this work. I should mention that I'm really presenting this modeling on behalf of Dr. Juan Vesga here, who is a colleague at Imperial College London, who has basically led on the modeling analysis that I'm going to show you. And also to so this is Juan here for folks who may not be familiar with him, but also I wanted to acknowledge the involvement of the very important involvement and input of other colleagues, including Saskia, Dennis, and Christian at WHL Montpellier, as well as Kevin and colleagues at McGill, and of course Gavin, who was very helpful in helping to shape some of our insights from the beginning of this work. So for participants who may not be so familiar about mathematical modeling and what it is that we're actually trying to achieve, as we know, transmission is very complicated, and tuberculosis is doubly complicated. And so mathematical models, it turns out, actually allow us to capture some of the essential dynamics of transmission using a system of mathematical equations. And when we've constructed a model for TB transmission in this way, we can actually use this then to explore the potential impact of different interventions on incidence and mortality over potentially long timescales. And so it's a helpful tool, not necessarily for predicting future impact, but more for if you like, projecting the potential implications of different interventions. But really, the focus here is on transmission and therefore on long-term trends in terms of incidence and mortality. And so in this piece of work, the two specific questions that we asked, and which I'll talk about in the next 10 minutes or so, were first, what would be the potential impact of some of the future preventive therapy regimens that are described in this document being launched, and in different countries with different TB burdens, but also what attributes of a future regimen would be most critical to keep an eye on in terms of being a driver of these potential impacts. So Christian earlier described some of the potentially key attributes in terms of implementation, and here we're asking similar questions, but from a transmission perspective. So just to concentrate on the first of these to begin with. So we looked at 4 different country settings: South Africa, Kenya, India, and Brazil. And as you can see in this table, I mean, these countries are widely varying in terms of the TB burden that they have. But also they're quite widely varying in terms of the amount of HIV co-infection as well. So with almost 60% of TB cases being HIV co-infected in South Africa, for example, all the way down to around 3% of cases in India. So between these countries, they actually represent a wide range for the intensity of TB transmission in these different settings, as well as the the importance of HIV as a driver of the TB epidemic. And so what we did in the model was basically to take each of these different country settings and then model full adoption of the WHO guidelines for the use of preventive therapy. And just as a reminder, I mean, there are several eligibility groups, but the two principal ones that we concentrated on here were all people living with HIV, undergoing HIV care, and all contacts of notified cases. So this is not just children, but also adults and adolescents. And as Tereza mentioned right at the beginning, there's been reasonably only modest uptake of current preventive therapy regimens, particularly amongst contacts. And so we're modeling a scenario where we can really ramp up coverage in future. And as a comparator, that's to say, in the absence of this future regimen, we assumed continued current coverage of 6H, continued indefinitely. So when we're thinking about a future regimen, here's a table that I borrowed from Christian's slides. These were the attributes that you've heard about from the previous presentation. Excuse me. These are the attributes you heard about from the previous presentation. And so for the purpose of the modeling, what we did was basically try and distill these into just a handful of attributes that we thought would be most important in terms of transmission and in terms of potential incidence and mortality impact of these regimens. And so we basically distilled these down to these 5 attributes here, which I'll talk a bit more about in a moment. But basically then equip this with quantifications for what we thought an optimal future regimen might be. So I'll say a little bit more a bit later about the minimal, the properties from a minimal future regimen. But for example, the duration of administration of the regimen, we assumed would be around 1 month. Its efficacy would be 100% reduction in incidence in a cohort receiving this therapy of people who are infected with drug-susceptible TB. And we also assumed that for drug-resistant, that perhaps there would be 50%, half this efficacy. Ease of adherence is basically a collection of different factors, including safety, tolerability, perhaps pill burden, and so on. But what we assumed was that all of those would aggregate in order to basically drive the completion rates that would be achievable under programmatic conditions. And so for an optimal future regimen, we're assuming a 90% completion rate. But also, amongst those who don't complete the regimen, it's also important to understand what the implications of non-completion might be. And so we have this additional attribute called forgiveness to non-completion, and this is defined as amongst those completing at least half of the regimen and then interrupting. We assume that 80% of those individuals would nonetheless get the full benefits of this regimen. And finally, you saw in the earlier slides, one of these attributes was the barrier to drug resistance. Here we're looking specifically at rifampicin resistance, and we're assuming a future regimen that has a complete barrier to rifampicin resistance, meaning that there's no induced resistance as a result of taking the regimen. So just to give you some idea of the epidemiological projections that resulted from this. So this is South Africa. On the left-hand side, I'm showing you TB incidence, and on the right-hand side, TB mortality. And this blue line is basically the baseline. So this is assuming the continued use of 6H at current levels of coverage. And if we implemented an optimal future regimen amongst PLHIV only, we would see a reduction over the next 15 years of around of about a quarter in cumulative incidence and almost 30% in terms of total TB mortality. If we then expanded this to include household contacts, then potentially with this optimal regimen, we could be averting up to 2/3 of cases over that period and around 60% of overall TB mortality over that time. So we repeated this exercise for the other countries that I mentioned as well. And so, for example, you see in Kenya, we might expect around a 47% decline in cumulative, sorry, here I'm just showing incidence. So 47% decline in incidence in India, roughly a similar amount of cumulative impact over the next 15 years. And Brazil, a smaller impact, but not forgetting that Brazil is a country with a lower baseline incidence to begin with. And so we're capturing here a range of epidemiological scenarios. So the second question we asked here was, when we look at this maximum potential impact that one could have under idealized conditions, which attribute of the regimen is most important in driving that impact? And so we became more focused here on the specific attributes. And so this is basically a table showing you the same attributes as I did earlier. Earlier, I showed you the optimal values here. But now we also have the minimal values. So basically what we did was to explore the whole range of scenarios between minimal and optimal, and take a combination of different regimen properties that span the range between minimal and optimal, and then try and identify which of these attributes are most predictive of incidence declines. And so it's a somewhat busy plot, but let me take South Africa as an example. This is what we term the partial reg correlation coefficient, but all this is basically a quantification of how important each of these regimen attributes are for incidence impact. Actually, let me take Kenya here in the top left panel. So the longer this bar, the more important this attribute is for incidence reductions. And just as one might expect, efficacy is coming out as the most important out of all of these 5 attributes that we're examining. But also interestingly, there's a secondary, strong, an important secondary role being played by ease of adherence, and also to some extent by forgiveness to non-completion. And interestingly, even though this is a range of different country settings, when we look at the impact of each attribute in each of these settings, then this is roughly, this is roughly consistent across the different country settings. So just to summarize, as I just mentioned, efficacy is the single most important predictor out of all of these regimen attributes. But ease of adherence and forgiveness also seem to play important modifying effects on overall incidence impact. And the countries that I showed you basically represent a range in terms of overall TB burden as well as HIV co-infection. But what we haven't addressed in this analysis is countries with a high burden of drug resistance, and the potential for rifampicin-containing preventive therapy regimens, for example, to be affected by the prevailing burden of drug resistance in a given country setting. So Juan is actually performing this work at the moment with colleagues from the WHO European region, and as we know, this is a region with, including countries with some of the highest burdens of drug resistance in the world. So watch this space for that analysis. But also watch this space for another piece that we've completed as part of this analysis that I haven't had time to go into today, but this is a deeper dive into how a regimen actually achieves a given efficacy. I've spoken in very sort of broad, non-committal terms about what we mean by efficacy, but of course, as we know, it could be driven by a range of pharmacological actions, ranging from the regimen actually killing a bacillary population all the way to suppressing its metabolism. And so we've extended this analysis to try and take account of some of those mechanisms and address for the purpose of understanding about the potential importance of different mechanisms, what those impacts on incidence might be as well. But in the interest of time, for now, let me close with acknowledgements. The very important folks that I mentioned right at the outset, but also the MRC Centre at Imperial College London, who actually contributed to us the funding for Juan's completion of this work. And finally, thank you all very much.
Thank you very much, Nim. I really liked the presentation, and it was really good to see how modeling can show what the potential impact is from these new TPT regimens with characteristics described in the TPTs, and also how it helped actually in the development of the target product profiles in sort of identifying which characteristics are the most important. and also exciting to see all the other research that you're still planning to do. We hope to have an opportunity to hear more about that sometime. Okay, with that, I would like then to invite Kevin Schwartzman to present on the cost and cost effectiveness of future TB preventive therapy regimens. So I think, Nim, you should stop sharing your screen, yeah? And then Kevin, you can share your slides, please.
Can you see the slides?
Yes, thank you.
Perfect. So good morning, good afternoon, good evening, and thank you very much to Saskia, Dennis, and colleagues at WHO for inviting us, well, first of all, to do this very interesting work, and secondly, to share some results today. And again, sort of like Nim, I need to underline that a lot of the work here was actually done by Placide and Sengyumva with other colleagues at McGill, as you see. In terms of disclosures, funding for TB modeling has come from the Canadian Institutes of Health Research and WHO. No conflicts of interest to disclose. So this work really builds on what you've just heard from Nim in terms of work that he and Juan did, and what this work did was to really try and add on some estimate of potential costs or savings and cost effectiveness for improved preventive therapy regimens, again, based on the epidemiologic projections we've just seen through 2035. In particular, we focused on 2 countries because of availability of cost data, as you'll see, and to make the work sort of manageable. So on the one hand, we considered Brazil, which of course, as has already been indicated, is a lower transmission, lower HIV prevalence setting. And South Africa, which of course is a much higher transmission and incidence and a higher HIV prevalence setting. So kind of anchoring the analysis in some sense at two ends of the spectrum, if you will, in terms of lower and middle income countries. So again, this is just a recap from what Nim has just shown. So again, we see again high incidence, high HIV prevalence in South Africa and both much lower in Brazil. And as was mentioned, this work considers the full adoption of the WHO guidelines for TPT using a future preventive regimen. On the one hand, all persons living with HIV, and then household contacts of all ages. We considered 4 primary scenarios for tuberculosis preventive therapy. The baseline, as was previously mentioned by Nim, being 6 months of daily isoniazid with current levels of coverage. The second of these, which I won't discuss in too much detail, but you'll see it on some of the subsequent slides, is actually expansion of treatment coverage with the regimen we now have most widely available, i.e. 6 months of daily isoniazid, but with attainment of the UN coverage targets. The third is preventive therapy with a regimen meeting the minimal attribute set, again reaching coverage targets, and finally the optimal regimen, again meeting UN coverage targets. Now we also considered in a sort of sensitivity or scenario analysis a regimen that would meet the minimal attribute set but be rifamycin free, so complete resistance barrier when it comes to rifamycins. The results from that won't be discussed in detail in this presentation, but some initial results or some high-level results are included in the TPP written document. In terms of the clinical outcomes we included in this analysis, and again, these are really derived directly from the epidemiologic readout from Nim and Juan. We included the number of persons started on preventive therapy in each country, or predicted to start, the number of persons predicted to develop both drug-resistant and drug-sensitive TB, deaths related to TB, and DALYs, which won't be discussed in detail today, but again, there's some information about that in the written document. In terms of the approach to costing, we used a bottom-up or micro-costing approach. This was used to estimate detailed costs related to TB and LTBI treatment in both countries. To be clear, this approach takes a deep dive into personnel and resource use from the health system perspective, so not the patient perspective, but considers a typical or average patient seeking care and considers all aspects of her or his trajectory. It includes personnel, equipment, supplies, medications, and other costs related to both outpatient and inpatient care. And again, in this context, considers both the treatment of latent TB infection as well as that of drug-sensitive and drug-resistant active TB. Wherever possible, we use data from the published literature. In some cases, this was supplemented by information from the national programs or other local stakeholders. Costs were expressed in 2019 US dollars, and for this analysis, we did not discount future costs or outcomes. So again, there's a lot of information on this slide, and I won't repeat it all in detail as these slides will be shared. But this is just, again, recapping the key regimen attributes on the top half of the slide and some of the key cost information on the lower half of the slide. So with respect to the TPT regimen, again, the baseline regimen is 6 months of isoniazid with the characteristics you see here, including 70% efficacy and 70% completion. With a minimal regimen, we see the same efficacy but improved completion, as well as improved forgiveness, and importantly, a shorter regimen. And finally, an optimal regimen having the attributes you see here, including 100% efficacy, very high treatment completion, forgiveness, and complete barrier to the development of secondary drug resistance. In the lower half, again, you see costs. So an important assumption here, which will be manipulated in subsequent sensitivity analyses, was that the medication costs for the new regimens should be similar to those for 6-INH. Now, obviously, if they're shorter, the per pill cost might be higher, or the per day cost might be higher, but the total medication cost would be similar. On the other hand, with shorter treatment regimens, we would expect that the ancillary costs of treating TB infection would fall, as there would be a requirement for fewer visits. In the optimal case, not only fewer visits, but less monitoring and a lower frequency of adverse events. So such that the cost would fall with the improved regimens, both in Brazil and in South Africa, again, not related to medication costs, but related to add-on costs of TB infection treatment. These costs for active TB treatment in the two countries are taken from the sources I've already mentioned, and of course don't vary by treatment regimen. These relate to treatment of drug-sensitive TB on the one hand and MDR on the other hand, and again in the two countries. So just to show some of the key results from the epidemiologic projections from Nim and Juan, and I realize this is a busy slide, so I'm just going to focus on a couple of points. So as we've already seen, despite what would be pretty massive scale up of preventive therapy in Brazil, the epidemiologic impact is not enormous with respect to TB cases. There's a modest decrease in TB cases, and likewise a modest decrease in TB deaths and of DALYs as well. In South Africa, again, for the reasons emphasized, i.e. high transmission, high incidence, high HIV prevalence, there's a much more marked impact. So you can see that with not quite doubling the number of people on TPT in order to reach HLM targets, we see a very substantial reduction in the number of people suffering from TB, both drug sensitive and MDR, a nearly 50% reduction in anticipated TB deaths, and a reduction in substantial and commensurate reduction in DALYs as well. Again, the details of these slides will be shared. When we come to costs, These, of course, track closely with the epidemiologic projections. And it's worth remembering that a lot of the costs, of course, relate to TB treatment, or the treatment and management of active TB disease, I should say, rather than the actual cost of delivering LTBI treatment. And so we see that in the case of Brazil, if we look at the baseline, it costs about, over the projection period from 2018 to 2035, we see a predicted cost estimate of about, $1.7 billion. Expanding 6H actually costs a bit more because, in fact, the treatment costs for LTBI are the same, and they're not off. You're treating more people, but this is not offset by major savings in TB disease. On the other hand, with the minimal regimen, which is shorter, and the optimal regimen, which is even shorter and substantially more efficacious, you do see some fairly limited cost savings. Again, I'll show you in absolute terms the cost savings in a subsequent slide. Again, as already implied by the previous discussion, the expected costs, on the one hand, the absolute costs are much higher in South Africa because of the TB burden. On the other hand, the cost impact with respect to savings of both expanded coverage with 6H, but more importantly with both the minimal and optimal new regimens is great. So again, we see tracking the improvement in morbidity and mortality, we see close to 50% reduction in expected costs with the optimal regimen, for example. And here on this slide, we see a summary of the, we're calling incremental costs, meaning the differences between two different situations. So for example, in the left-hand column, we're seeing the difference in costs between expanded use of the 6-month isoniazid regimen to reach UN targets versus the current level of coverage. And we see that actually, as mentioned previously in Brazil, this is associated with a modest increase in costs, whereas in South Africa, even expansion of the existing regimen to meet UN targets is associated with substantial cost savings, approximately $900 million over the time course simulated or projected. On the other hand, if we compare the minimal TPP regimen with the baseline level of 6-INH coverage, we see even more substantial savings in South Africa on the order of $1.6 billion, and more modest, but nonetheless some savings in Brazil. And finally, with the optimal regimen, we see, of course, even greater savings relative to the current situation. So anticipated savings of approximately $2 billion in South Africa and about 60 million in Brazil, again, over the roughly 20-year modeling period. Finally, if we think about it in incremental terms, again, for every TB case averted, in most cases, there are actually associated savings. Certainly that's true across the board in South Africa, with the associated savings per TB case increasing with the quality of the regimen. In Brazil, we see an increased cost per TB case averted when we compare expanded coverage of the existing 6H regimen with current coverage levels, but then again, actually cost savings as better regimens would be implemented. So just to wrap up, so again, in keeping very much consistent with the epidemiologic projections, expanded coverage for TB preventive therapy using the posited regimens with the minimal and optimal profiles is expected to lead to substantial cost savings in settings like South Africa, where there's high HIV prevalence and a high degree of TB transmission. There will likely also be savings in settings where the incidence and transmission are much less substantial and HIV prevalence is likewise lower. These will of course be more modest, but likely to be present nonetheless. And importantly, I bring you back to the assumption that the cost of the actual medication would be the same for a new regimen as for the current 6-INH regimen. But given the magnitude magnitude of the cost savings in high burden settings like South Africa, it's likely that even with higher costs for the medication regimen itself, there would still be overall cost savings in such settings. So I just want to wrap up with thanks again to our colleagues at Nim and Juan at Imperial College London, to Dennis, Saskia from WHO, to Christian, who I've also heard this morning from Montpellier, Annette, who's been an important colleague in Brazil, and then many others for input into this work. So I'll wrap it up there, and thank you very much. And I will stop screen sharing.
Thanks very much, Kevin. We always like to see when new interventions are cost effective, but even better if they are cost saving. So that's very encouraging. Thank you so much. Then I would like to pass on to Alberto Matteelli, who will present to us some use case scenarios and considerations for special populations. So Alberto, please share your screen. Yeah, we can see it. Maybe you can make it a full screen presentation. Yeah, that's perfect. Thank you so much. Alberto, are you unmuted? You're still muted, huh? At the bottom left, you can unmute. No. I think if you move I think at the bottom of your screen on the left, on the sign of the microphone, you should be able to unmute. Otherwise, I can try to do it if someone can unmute you from here.
Can you hear me now?
Yes, thanks, Alberto. Go ahead, please.
Yeah. But now I need to go back to my presentation, and that I cannot see it.
Okay, we can see your presentation.
You can see it?
Yeah.
Okay. And is it full screen?
No.
What about now?
Yes, now it is. Now it is.
Perfect. Sorry for this problem. So I will just bring few thoughts about basically the target population for a TPT strategy, which are also discussed in the publication. And starting from few elements which are at the basis of the document itself. First of all, that candidates for a preventive therapy strategy should, as much as possible, not differentiate about the target population. So if you can target all individuals at risk for developing TB, this is a great plus for a global strategy. And this is true in terms of safety, tolerability, and effectiveness of the treatment regimen for different population groups, but also for individuals within different populations and according to their comorbidities. These concepts include also a discussion about drug-drug interactions, because some of the comorbidities do require use of drugs, and these might interfere with the drugs that we use for preventive therapy. As much as possible, our treatment formulation should be oral rather than parenteral, and the dosing schedule should be as simple as possible, and most importantly, suitable for children. Recommended drugs should be available and affordable, especially in low and middle income countries. The recommended medicines should be available all over the country, and particularly in decentralized places. And the monitoring of side effects to these drugs should be as easy as possible, and do not require for testing or sequential testing. There are different issues, whether we talk about high incidence settings or low incidence settings, although as much as possible the guidelines do apply to the whole set of countries in the world. But I mean, these are the results of a quickly evolving situation. 5 years ago, for example, at the time of the first ever guideline, then talking about preventive therapy in high incidence countries was basically a taboo. Now we understand that this strategy is important for high incidence countries as well, but we may be aware that the effect of the intervention may be transient, may not be lifelong, because of the intensity of transmission that will bring to new infection once the old one has been cleared. And because of this, then we might decide in this setting to concentrate on very high risk population, like people living with HIV, or household contacts of contagious cases who are very young, and particularly below the age of 5 years. On the contrary, for low incidence settings, we understand that the total benefit of an RTBI strategy is less, because infection is less prevalent. But the protective effect is much long-lasting, and possibly might be lifelong, might have a lifelong duration. Because of all these elements, then the population groups that are targeted for the intervention are broader compared to high incidence countries, and might contain prisoners, health workers, immigrants, homeless, and people who inject drugs. Another important consideration, and that we should always consider treatment and testing as two strictly correlated tools. Currently, our testing tool is much less than ideal if we think that less than 10% of the people that we identify as candidate for preventive therapy on the basis of a positive test, only 10% or less than 10% will in fact develop the disease in the near future. So these definitely dilute the impact of treatment and amplify the risk of side effects for undue treatment. This just to say that the development of cheaper, rapid, and more accurate diagnostic tests will have an impact also on the population that we target for our treatment interventions. So a few words on these special populations: children, pregnant women, and people living with HIV. Concerning children, in the latest version, this table is from the latest version of the WHO guidelines, and you see that the recommended dose of TB medicines for prevention are based on weight, and particularly younger people, and the threshold here is 10 years, receive a dose which is basically double compared to the adult population. And you can also see from here that if we talk about rifampicin, isoniazid, or the combination of two, there is no lower limit as these medicines are safe for any age group. Among the other recommended treatment regimens, the 12-week rifampicin isoniazid combination is recommended for people above the age of 2, because there are few data on safety below the age of 2 years. Here again, the dosages are on the basis of the weight, starting from 10 kilograms and above. And finally, concerning other recommended regimens, the regimen of rifampicin plus isoniazid monthly has been basically studied all in the population above the age of 13 years, and because of this, it is currently recommended above the age of 13 years, and the dosage, the recommended dosages, is not on the basis of weight. You can also see here that there are recommendations for levofloxacin for the treatment of cases or contacts of NDR-TB. And although quinolones are usually not indicated in children, but in this case you can see that there is a recommendation of dosing above the weight of 5 kilograms in case the clinician decide to use this preventive regimen. So in summary, we have no problem with isoniazid or rifampicin. We have some limitations for rifampicin, age limitations, I mean, above the age of 2, if we use it weekly for 12 weeks, and the age of 13, if we use it monthly for 4 weeks. And finally, for the fluoroquinolones, the data on safety for kids are very limited. There is a usual contraindications on the use of these drugs in the pediatric age, but for prevention of MDR, which is a very serious condition, then the clinician can take the responsibility of prescribing the drug and then obtaining a written informed consent by the parents. In the pregnant and breastfeeding population, you definitely heard about the issues of toxicity in pregnancy attributed to isoniazid, which came from the publication of one randomized controlled trial that was conducted in Africa, and that showed a significantly higher risk of fetal toxicity, including neonatal or fetal death, prematurity, low birth weight, and congenital abnormalities in women receiving isoniazid. Under the initiative of WHO, a meta-analysis has been conducted to deepen our knowledge on this issue. These meta-analyses contain 3 additional non-randomized comparative observational studies, and all these 3 did not identify any excess of adverse neonatal events in women receiving isoniazid. So for the time being, isoniazid continues to be indicated for the prevention of tuberculosis in pregnancy. And as far as the other medicines are concerned in pregnant women, there are no concerns of rifampicin. There are concerns of rifampicin, basically because the data on pharmacokinetic and safety in pregnancy are very limited, and is the reason for the absence of wide indications so far for the 1 HP regimen in pregnant women. But pharmacokinetic studies are ongoing, should be soon published, and probably opening the way also for the use of this drug in pregnancy. I just remind you that the recommendation for monitoring of treatment safety during pregnancy are not really different from the general population. Baseline hematochemical investigation, including liver functions test and full blood count, are not systematically recommended. They are encouraged whenever feasible, but if this is infeasible, then it's not a reason not to go for treatment. And the same is true for vitamin B6 supplementation that should be considered and adopted whenever this medicine is available, but its absence is not a contraindication to the intervention. And finally, the population of people living with HIV and the problem of drug-drug interaction between anti-TB medicines and medicines for HIV. The problem exists because rifamycins are inducers of the cytochrome P450, which also metabolize HIV medicines together with a large number of other medicines. And the result is that the metabolized drug is quickly removed from the blood, thus reducing the blood concentration of the drug. The effect is different on different antiretroviral medicines. It is of no clinical relevance for efavirenz and serraltegravir that can be normally used at usual dosages together with a rifampicin containing treatment for tuberculosis. Dolutegravir is in a middle situation. That's an important drug because now it's widely recommended in first-line HIV treatment worldwide. And here there is an effect that requires doubling the doses of dolutegravir while this drug is taken with rifampicin. But this is apparently a manageable problem at program level. On the contrary, there are other HIV medicines like all protease inhibitors and nevirapine that should not be used together with rifampicin because otherwise the blood concentration will be completely ineffective. And that was my last slide. I also want to acknowledge all the people that participated to the meeting in Canada last August and contributed to the preparation of these guidelines. Thank you very much for your attention.
Thank you, Alberto. It's really great to have some extra focus on the special key populations. And these should also be considered, of course, with the development of new regimens for TPT. Then we've received some questions on the Q&A. Christian, I think you're going to lead the Q&A, so I'll give the floor to you again.
Thank you very much, Saskia. So I have to open the Q&A again. So some are open and some are supposed to be resolved.
No, I think they're also. I think they haven't been answered yet.
Okay.
But we've moved some. If we've taken note of those questions, we moved them, so they're both still open.
Okay, very good. So first we have a question about the measure of efficacy, and do we currently have an idea of how long the protective effect of 3HP of other newer regimens last? And then there is a mention that data from Botswana with 30 months IPT showed the protective effect to wane with time over a year. So the person you see was wondering what we are seeing with new regimens. So this is again an important question, and we address that in TPT about the duration administration, and then the effect of that will the protective effect or the duration of the protective effect behind treatment. So that's where we must make the case of the implementation of the TPT. that can be different, whether we are considering the high incidence and low incidence countries, because in high incidence countries, in a high TB endemic country, then the possibility of having a new reinfection is higher than in low-income countries. So therefore, especially for people living with HIV, the risk of being reinfected is quite high, with which then would appear as having a limited effect of the TB preventive treatment. This has been alluded to by Alberto in his presentation. And then I would like to ask him to give his opinion. But what I would like to mention about the specific effect of the 3HP, there has been within the big impact for TB trial, there's a trial of repeating provision of 3HP after a year. I'm not aware of the results. I don't know whether somebody is aware of the results or whether, I know it was supposed to be presented at CROI in March, but CROI didn't take place or virtually. So I'm not sure if there is any type of knowledge of that. So would you mind, Alberto, please responding, giving your opinion about the issue of the waning effect seen under the 36 months IPT and the difference of effect of TB preventive therapy according to the endemicity and the situation in the various sites. Thank you.
Thank you. Thank you very much. And well, concerning the first question, whether there are ongoing research, I think that yes. Gavin Churchard, to my knowledge, is leading a group of researchers that worldwide is performing a very large scale millionaire trial on repeated yearly course of 12 weeks of HP, because as correctly we're mentioning, there are data from Sub-Saharan Africa showing that data of about 10 years ago, which shows that the durability of one course for preventive therapy is about 18 months in high transmission areas. So that would be the duration of protective effect. And of course, I mean, if you're using a LTBI test to define whether an infection occurred or not, this does not apply to reinfections because I mean, a positive LTBI test is not supposed to revert to negative after treatment. So that will remain positive, and that's it. So I think is basically, to me, is basically a question for TB programs who are hosted in very high transmission areas to decide whether they want to go for repeated or long life courses of preventive therapy.
Thank you very much, Alberto. So I guess now with these two interventions, the response has been addressed. So I'm going to the next one by David Omotayo, who is asking, what do you mean by forgiveness? So Denise Falzon responded that this refers to the impact of the extent of interruptions in dosing on its efficacy. Nim, you used first the notion of forgiveness. Would you like to clarify a little bit more, please? Thank you.
Sure. Sure. And thank you for the question. I should mention in an early version of this modeling, we took a very simple approach, as we always do with the earliest draft of any modeling, to assume that if somebody comes off preventive therapy early, if you have an early interruption, then they would revert to as though they had never taken preventive therapy. And that it doesn't matter how long they had taken that regimen for, and how well they are taking the regimen, but that as soon as you interrupt, you're losing any protective effect. And of course, that was unrealistic. And in refining the model, we needed to address this kind of simplification. And so it raised the question of what does the duration of a regimen actually mean for the protective effect that one could have. Rather than trying to theorize, what this might mean, because this is a question that needs an actual, study under trial conditions, not a model. Instead, what we did was to make this assumption, to say that 50%, people who had completed 50% of their regimen and are then interrupting after completing that, what proportion of those people would nonetheless get the full impact, the full benefit of the regimen? And I should mention, in response to another question as well, that 50% is also an assumption. And in principle, we don't know what in case of future regimens that number would be. Would it be 30 or 70? I mean, again, it is a matter for trials of those future regimens, hopefully to address. But in short, forgiveness basically, in this sense, means if you have taken a certain amount of your regimen and have then interrupted, what is the chance that you still have the full benefit of that regimen? And understanding that this threshold amount is simply a model assumption.
Very good. Thank you very much, Nim. So the idea of the effectiveness of forgiveness is a highly forgiving regimen is one that even if you stop it before, will still have a very strong effect. And a regimen that is not being forgiven is that it doesn't allow you to interrupt it before you have completed it. So I guess this is fine. Thank you very much again, Nim. So the following question from Gerard De Vries is about the issue about effective TPT regimens in low burden countries. I see that Denise has responded to this question. Would you like to take that on, Denise, further or not? Do you think it is fine?
Hi, yes. So I think the specific issue here is about the approval of rifampicin in the European Medicines Agency, and this is an issue which has been long-standing. So partly it could be solved by advocacy from countries which are demanding, and partly by submission by the manufacturer to the EMA for a dossier and to fulfill the requirements also for the pediatric population, which is of course the limit on the age which is applies throughout. It's not just for the European version. Thanks.
Very good. Thank you very much, Denise. So then the next question: have those to prevent TB in people receiving? I think that was being addressed by Nim. Yeah, and you have responded. Assumption for modeling purpose is within it's necessary to a sensitivity analysis. When we assume a higher proportion, instead the results are essentially the same, but we find that the importance of forgiveness decreases. So that was for the forgiveness aspect. So now a question about treatment costs, which is Masimba Dube. I didn't quite understand how you got to treatment costs. It seems they are the same across countries, which one would not expect due to price variations across markets. So Kevin, would you like to take that question on, please?
Sure, I answered it in the chat also, but yes, in fact, we did assume different costs for Brazil and South Africa. I think maybe I can put up the slide once again if it's helpful, but we did in fact consider different treatment costs for both TB infection and drug sensitive and drug resistant TB in the two countries. And again, this reflected a fairly extensive micro costing exercise. So when you, in fact, the information is, I think, contained in the written TPP document, and also when the slides are shared, you will see this.
Yes, and in fact, what is important is to understand that this detailed micro costing from the things vary, because a lot of things are varying according to countries in terms of cost being spent by patients for consultation, for diagnosis, for treatment, etc. So I guess one cannot assume that the costs, in fact, are the same across countries. Okay, then we have a question from Guy Stalworthy on AP modeling, so I read it. The AP modeling explored the relative impact of 5 treatment attributes under conditions of full coverage and suggested that efficacy is far more important than duration. For example, given the challenge in achieving coverage to date, was there any effort to explore which attributes are likely to have the greatest role in determining coverage? Is it possible that cost and duration, for instance, might emerge as more important than efficacy in determining life real impact? So I think this is quite an interesting questions. I see that you started responding, Nim, but would you like to take it on, please?
Yes, it's actually worth actually discussing that question because I think it is a really important one. In the modeling, it's very important for us to be clear that we are assuming that there is absolutely frictionless delivery of these preventive therapy regimens. So we're not addressing the very important factors in this question, which is that a future regimen that costs that has an extremely high cost would simply not be feasible to deploy at the scale that we're modeling. And also there may be other elements of that, including, for example, the pill burden, the duration of the regimen, and so on. We have not addressed those here. As I say, we are assuming perfect deployment of such a regimen, but I agree this would be something that's important to address for any future regimen. And also I'd add to that when we're looking at the coverage of current regimens amongst household contacts, for example, it seems, at least anecdotally, it seems as though one of the real barriers is not necessarily the characteristic of the regimen itself, but also the acceptability amongst individuals that might otherwise feel healthy. And so there may well be extra regimen factors as well that we have to think about in the scalability of any future regimen.
Very good. Thank you very much, Nim. So the following question is from Edio from Brazil. It's a long question, but basically Edio is referring to the implementation of a new regimen. So the TPP here are about the product that we would like the developers to be focusing on. And Edio is considering once the product is being ready and approved by the regulatory authorities, recommended by WHO, what about the implementation of the regimen? So Edio is focusing on the beyond aspects about how to work with NTPs to provide the TPT. I see that Denise started responding to that. Would you like to take down more on that? Denise, please.
Yeah, I think it's a very important point that raises about the sort of the barrier in people's minds as well about the use of TPT and how they prioritize the preventive actions and in contrast to all the workload that they have to treat TB patients, right? So I think it's important to consider that this is another area which needs to be addressed within TB programs. It's like I'm trying to run a vaccine program, more or less, right, to try and prevent. So it's important that they prioritize this alongside the other work that they need to do on treatment. And I think the discussion we have today addresses as well part of that, right? Because making regimens easier to give, cheaper, faster to complete, safer, less interactions, etc., would go further way to convince people more to use them and to offer them to people who do not have symptoms. So it's an important part of this argument. But I think the ownership, as Ezio puts it, by NTPs, and we try to engage with NTPs and other stakeholders, civil society communities early on in many of our activities, which end up in guidelines in documents such as the TPP document here, which went out to public consultation, and we had a very lively discussion about this when it was still in draft. Is extremely important, and it's part of the way of trying to get more ownership. Again, this word is very good. And I think Jean-Pierre Zellweger as well had a similar point about kind of convincing doctors to adopt TPT. So again, these are continual advocacy methods that and messages that we need to give, and they need to be sort of linked up to other activities that we are doing, such as the one of today. Thanks.
Yes, thank you very much, Denise, and I fully support what you say. And you have taken on the questions by Jean-Pierre, who was on the same aspects of Jean-Pierre Zellweger about the fact that medical doctors would not consider intervention in healthy people. So I think this is all the aspects about how best to implement something like a TB preventive therapy, which is complex in the sense that we intervene with people who are not sick. We give them drugs, and there is a high level of sensitivity about that. So I think that's very clear. Another question, it's not a question, it's a comment by Gerard de Vries, who give the knowledge about a letter sent to Sanofi and related to what EMA is requesting for approval of the rifampicin. So EMA is requesting a pediatric investigation plan. I guess what would be good is to see the letter. I see that Gerard is asking about what Alberto mentioned about the data being scarce for rifampicin treatment in children less than 2 years. This is unfortunately the situation. I understand that there are currently some PK studies being conducted in order to try and know better about the dosage of rifampicin together with with the isoniazid in the 3HP scheme. And these results are, I mean, the study is going on at present, and I guess that will add to the results that are unfortunately still scarce on the use of treatment of rifampicin treatment in children. So these data are being awaited. So I think that's Saskia. Would you mind telling me whether all the responses have been? No, I can see there are more.
Yes, there's some more under open question.
Yes. So Anthony Harris is asking about what do we know about interaction between rifampicin and methadone in person injecting drugs and women on oral contraceptives. I'm afraid I do not. I wonder whether some people here would have this notion about the interaction between rifampicin and methadone in persons injecting drugs. Denise or Alberto, would one of you know about this issue?
No, unfortunately, I don't. I'm pretty sure it's an important topic because the effect of rifampicin are quite massive on methadone metabolism. So although rifampicin is a lesser as a lower action, but still, I guess this is an important topic.
Okay, very good.
Christian, can I add that we have not specifically to rifampicin, but we have, of course, in the target product profiles a notion of that the new regimen should be possible to use in people who are on methadone, and also in people who inject drugs, as well as women on oral contraceptives. So these issues are highlighted in the TPPs.
Yes, thank you very much, Saskia. That's a very important addition, that this aspect is being considered in the new target product profiles. So I think that's fine. Lucy is thanking Nim for his clarification, which is good. Then an anonymous person is asking how can we increase the optimal reach of MDR patients at community level, which is, I guess, a different questions, because here we are not speaking so much about MDR TB as such, neither reaching MDR patients. what we considered in the TPP is the fact that ideally the new products, either a regimen or a drug, should be able to be given to persons who are contact of MDR-TB patients, so that they can effectively get rid of the infection with resistant bacilli. So I guess this is mainly related to what is being taking place at programmatic level about treatment of persons with MDR-TB, and then the consideration of going to the households of these persons with MDR-TB, looking at the household contacts and trying to find out who was exposed, and then considering the use of TB preventive therapy. It's true that there is not so much knowledge now. Alberto has mentioned about the use of levofloxacin. There are 3 trials currently ongoing who are testing either levofloxacin or delamanid in order to try and see the better activity of drugs for the preventive treatment of TB in the context of MDR-TB cases. So this is the situation. Now about the methadone, I see that Andrew Vernon, who is online, is mentioning that there may be data on methadone and 3HP in the study 26 PreventTB database, which will be shortly accessible to qualified researchers through the CPTR TB-PACS platform. So this is an incentive to try and use the TB-PACS platform, which is a platform established by the CPTR, the Critical Path to TB Regimen, to collect trials on TB treatment and to get best access to the database. So I guess that could be an interesting area to do for more research. I think I'm off now with all the questions. I just look whether under those which have been reserved there are I think all of these have been addressed. Yeah. For the open question, Ezio is responding to Denise and is mentioning about the extremely important aspects of the NTP being involved early in the ownership of generalizing preventive therapy for TB at country level, which is, I think, again, something extremely well taken. That this aspect being high on the agenda when ideal regimen would be available for introducing in countries. So
thanks, Christian. I think we've gone through all the questions that were in the Q&A as far as I can see. Or are there
there's a couple more.
Some new questions? Okay, so we have some new.
Davido Motayo is asking, considering the fact that fluoroquinolone are readily available for purchase in most pharmacy shop outlets and use it again as preventive therapy, is it not going to increase the risk of resistance to the group of the medicines? So here, I mean, Alberto will be able to complement that, but we are not saying that we need to give levofloxacins or fluoroquinolone for the treatment of TB infection. It's been proposed for the treatment of TB infection in contacts of MDR-TB. And again, the purpose of the presentation today was not about the management of TB infection, but more about the new products that can be developed and that should be developed, and how WHO is putting in a very concise type document the main attributes of the ideal regimen to be developed. As far as the treatment of preventive therapy currently is being recommended, I would like to alert here the audience on the fact that WHO has published on World TB Day this year, 24th of March, the latest guidelines on the treatment of TB infection, and these are available at the WHO site. I don't know, Saskia or Denise, whether you would like to complement my response here.
Yes, indeed. And there was a question about this, and there's another one about kind of indiscriminate use of fluoroquinolones from pharmacies. So I think it's important to understand that there is a recommendation on the use of TPT for people exposed to MDR-TB. So it is a condition recommendation. The evidence base is relatively weak at this point in time, but as you said, Christian, there are trials ongoing, so within a few years we should have stronger evidence for this. And the condition recommendation was a bit further elaborated this year in the operational handbook that came out with the guidelines in March during World TB Day. And there's been a bit more explanation. There is a dosage for levofloxacin that is given, and some more explanation about conditions that apply when to use it, and that surveillance continues even after the treatment. So it's a bit different from the general recommendation on TPT for non-resistant TB.
Yes, thank you very much for the clarification, Denise. So the last question which I see on my screen is from Pedro CRS. And the question is, the EP modeling projection estimates an important reduction in TB incidence in countries like South Africa. Did you include the impact of other TB interventions, such as early detection and quality treatment for both drug-susceptible and drug-resistant TB? Please, Nim, would you mind responding to Pedro here?
Yes, of course. I think this is one for me. So in the modeling, we can consider the impact of improved standard of care of TB in the baseline, but in this case, we kept this baseline very clean. So what we assumed was that there were no background improvements in detection and quality treatment for DS and DR-TB. What that implies is if you have additional improvements in the TB, active TB treatment cascade, then you would see even greater incidence reductions than what we're seeing here. And I also wanted to add, this is in South Africa at least showing a large potential impact. And part of the reason I think for this is also that in South Africa, UNAIDS estimates, if I remember correctly, suggest that around perhaps 60% of HIV prevalence is actually on treatment. And so by reaching household, by expanding coverage amongst household contacts, we're also reaching potentially unrecognized cases of HIV that have not yet been recruited onto treatment. And so a lot of the impact that we're seeing through bringing in household contacts on incidence is partly because of this recruitment of HIV, people living with HIV who haven't actually accessed ART yet. So one can understand, at least epidemiologically, the reason for that impact. But in short, in answer to your question, we have just assumed that the current standard of care continues indefinitely, and we would see bigger incidence reductions if we include those interventions as well.
Thank you very much, Nim. I think this is very clear. So, Saskia, my impression is that we have gone through all the questions. I don't think that we have forgotten any, so I'm sending back the floor to you, and I really would like to thank everybody for the question, and especially the intervenants and people here for the very high quality response provided. So thank you very much, and Saskia, I give back the floor to you. Thank you.
Thanks, Christian. Thanks. I would also like to thank all the presenters for joining today and presenting their work. And I would also like to thank the audience for their interest and participation. I thought the questions asked were excellent and made for a really lively Q&A session. So thanks very much. And I'd like to encourage you to find the target product profiles for TB preventive treatment on the WHO website, on the website of the Global TB Program, and read through and share them among your network. I'd like to inform you that this webinar will be posted online, so it should be available for later reference as well. So thanks very much. I think with this we've come to the end of the launch of the target product profiles. So thanks very much, and for your interest and for joining today.